Hi, everyone, and thank you for watching this webinar hosted by the GLODEM Trainee Committee. This is going to be a special edition that's going to shed light on the ongoing outbreak of monkeypox. I, Dr. Dorian from Tanzania, and my colleague, Dr. Luisa Apollo from Brazil, are going to host this meeting. And we are delighted to have our special speaker of today, Dr. Pablo Fernandez Gonzalez, an expert in tropical dermatology currently working in Spain. For people who are hearing us for the first time, as I said, we are the GLODEM Trainee Committee, which is a wing of the International Alliance for Global Health Dermatology, GLODEM in short. And we usually host free educative webinars every month. And our primary goal is to promote knowledge equity by improving access of education for dermatology training across the world. So before I give space for Dr. Pablo to give us his very educative talk on monkeypox, I would like to briefly introduce him. So Dr. Pablo Fernandez is a consultant dermatologist at Ramon y Cajal Hospital, a teaching hospital in Madrid. He has interest in infectious disease, and he holds a master's degree in tropical medicine. He had collaborated with a lot of dermatologists with the same expertise, and he has also experience in working in tropical countries such as Tanzania, where I met him for the first time, Ethiopia, and Peru. So Dr. Pablo, I am very happy to welcome you to give your talk on monkeypox.
Thank you very much, Dorian, for your kind presentation. I'm very happy to stay here with you to talk about this interesting topic that we have faced this month and that is currently happening. Well, I will share my presentation and we can start then. Okay, so as Dorian has said, I am very interested in tropical and infectious diseases regarding all dermatologic manifestations. Now, we are going to talk about the monkeypox outbreak that we have faced this month in Europe. Well, I would like to start with a brief introduction about pox virus and, of course, monkeypox virus and its biology and its pathophysiology, because I think it's very important to understand these features, to understand them better, the clinical manifestations, and how this virus behaves in humans. And of course, after we will talk more in detail about the current outbreak, and we will be able to discuss and highlight the epidemic and our experience. So, what we knew about pox virus and monkeypox virus before the current outbreak. Well, it's important to know that in the mid-50s of the last century, there was an interest of knowing if human smallpox could be present in animal reservoirs. This was so because it was an increase and an important interest to eradicate human pox virus. So first, they had to know if the animal reservoirs could then spread the disease again among humans, and so the human vaccination would be effective to the eradication. One of the main researchers who began with this work was a Danish who discovered it in a fortuitous and a casual way that there was a disease similar to human smallpox that affected monkeys. These monkeys that presented the disease was this called crab eaters monkeys, and the investigator was von Magnus and its Danish research group. In the same way, other researchers started to investigate about other pox virus, and they found in the next years that pox virus were very common in other reservoirs, different from the monkeys, especially rodents and mice. Well, once the monkeypox virus were well established and were defined, and also after the eradication of a human pox virus disease, many other outbreaks related to monkeypox started to appear. Until then, it was really difficult to differentiate between the human pox virus, the variola major, and monkeypox, because the diseases were very similar. And also in those years, we didn't have molecular techniques to diagnose. So once the variola major was eradicated, the monkeypox outbreaks were more common in endemic areas. These endemic areas were mainly Central African countries and Occidental and West African countries such as Nigeria, Democratic Republic of Congo, and other surrounding countries. Well, then in the starting of the 21st century, more outbreaks started to appear and started to be defined of monkeypox. Almost all the outbreaks were constant contact with animals prior to the appearance of the symptoms. And also, it is important to know that in many outbreaks, the affection was mainly in children. Why? Because the vaccinated population started to decrease, and the children who were born after 1980 or in the 90s were not vaccinated for smallpox, so they were more susceptible to monkeypox infection. Well, an important outbreak that occurred in 2003 was an outbreak related to prairie dogs. These prairie dogs were mixed with Gambian rats. Gambian rats is thought to be one of the major reservoirs for monkeypox. And these prairie dogs are often sold in the United States and in other countries as pets for general population. So these prairie dogs were infected by monkeypox and then caused an outbreak in the United States in 2003 with 81 cases, the majority of them in adults, but without any death. We will speak about this outbreak a little more later. Well, of course, in endemic areas, during all these years, there have been several other outbreaks, especially in Democratic Republic of Congo and Nigeria. It is important, the outbreak in Nigeria, because it allowed us to better understand the disease. It mainly affected children, and in this outbreak, the mortality rate was high. Okay, but these mortality rates depend a lot on the clade of the virus, which we will speak about it later. So, to sum up the history of monkeypox, what we knew until the current outbreak? Well, we knew that we had to start preparing for the pox virus, not just because the threat of bioterrorism that has always existed with variola, but also because the more common outbreaks of monkeypox that we were facing nowadays. And also, we knew that an epidemic outbreak could happen and could be emergent viral disease in our area. Okay. So, as all the epidemics and all the infectious diseases, this started suddenly. In May 2022, the first cases started to appear in Spain and Europe, but with different features that we already knew, that we knew before the outbreak. But it's very important that we should not forget that this disease that is affecting now here in our countries is still endemic in many countries in Africa, and that now we are seeing that the incidence in our countries is decreasing. But we must not forget that we have still cases in these endemic countries, and we have to put all the efforts to control and to watch out and to violate this disease in these countries, in order to not just current outbreaks in our countries, but also to control in the areas more affected. Okay, what about pox viruses? Pox viruses have some very interesting peculiarities. First thing we need to know is that monkey virus belongs to the genus Orthopox virus. Orthopox virus. Within this genus, we find the human smallpox virus, but also monkeypox virus, cowpox virus, the variola of camels, and the vaccine virus that is used to the production of vaccines against not just variola major, but also monkeypox virus. On the other hand, we have also the mollusk virus that is not orthopox virus, but it just affects human beings. Okay. The rest are all zoonoses. So this is important to know, but because if a viral disease is a zoonosis, it is very difficult to eradicate. We can eradicate those diseases that just or only affect humans. Another peculiarity of the pox virus is that these viruses have a very long genome. They are one of the largest viruses known that exist, and it has a double strain DNA. The fact that they are DNA viruses is an important characteristic to understand how they behave at the biological level. Okay, in this slide we can see with electron microscopy the shape that some viruses have compared to other viruses that have also very large, such as herpes virus. But here, look here at this very interesting picture that compares different cell size. Human smallpox virus, that is very similar to monkeypox virus, has a much larger size than other viruses, such as the poliovirus or coronavirus. This genome so long allows it to encode a multitude of genes that will provide its main characteristics. Mainly the preference or diversity for the species. For example, variola major virus has preference for humans, but monkeypox virus can infect not just rodents, not just monkeys, not just humans, but also other mammals. But also immunomodulation. These genes allow the monkeypox virus to immunomodulate our immune system to hide from it, and also the pathogenic mechanism that they have. From the point of view of pathophysiology, there was a very interesting work in the 50s carried out by Fenner, in which he studied the pox of mice, and he described the main pathogenic processes of these viruses. In this sense, it seems that after the first contact, there is a first viremia with low titers, with little viral load. Subsequently, the virus accesses intermediate organs such as the liver, such as the spleen, or the lymph nodes, where it develops, where it replicates, and to lead to second viremia with more viral load, and then the virus reaches the target organs, such as and mainly the skin. In this other diagram, we can see how the virus accesses through the skin and how Langerhans cells play a very important role in this movement of the virus through the organs. And in its replication, it is thought that inside these cells, these Langerhans cells, the virus can replicate. In fact, there is a hypothesis that speaks of the development of cutaneous manifestation has to do with the migration of Langerhans cells through the skin with the virus inside. Also, the host immune response to this virus, to monkeypox virus and the rest of pox virus, probably involves all weapons of the immune system, like the antibodies, humoral immune system, complement, interferon, and natural killer and T cells. Sorry. Well, the pox virus, thanks to his large genome and the proteins that they encode, they have a very important capacity for immunomodulation and immunoevasion. This virus can neutralize antibodies, they can block complement or interferon, and they can also inhibit the apoptosis produced by natural killer cells and lymphocytes too. To note, difference between the pathogenic symptoms of the different clades are also related to changes with these genes. And regarding the clades, it has been a lot of talk about the clades. Well, these clades are thought to have a very important pathogenic role in the current, not just in the current outbreak, but in the outbreaks and in the endemic countries where cases of monkeypox occur. There are two types of clades that have been defined. The clade number one, which is formally known as Central African clade, it is one of the clades with more severity and with more mortality. The clade 2, which is formally known as the West African clade, it is the one that is affecting the current outbreak. But it is important to know that after the analysis of the genes of the cases that we have faced in this outbreak, it has been defined a new clade that is called B1, which is the mainly clade that is affected us. And this is important because there are 50 single nucleotide polymorphisms that have been described. And these polymorphisms affect proteins that are involved in human transmission, virulence, or interaction with antiviral drugs. Actually, a leading hypothesis proposed that the 3 non-synonymous single nucleotide polymorphisms, which are found in the surface of a glycoprotein of this virus, are enhancing the transmissibility of the virus. So this could explain why right now we are facing an outbreak in our area, and that this outbreak is so contagious among human beings. So the virus is undoubtedly changing, maybe in an accelerated way, but I want to insist that some of these changes may be related to some observed polymorphism, but these are just hypotheses and that generate controversy, and that may be studied and will be defined properly in the future. Well, about the clinical manifestation of the classical disease, what we knew. Okay, the incubation period from the exposure to the onset of the clinical symptoms are things where it's thought to be about 10 to 14 days during those outbreaks. Patients were infectious during the first weeks of the RAS, and should have been isolated. But during these outbreaks in the endemic countries, the isolation was not as easy as we may think, for example, in our area. So it was common to have an explosion of cases during the outbreaks. An interesting point is that almost 75% of the cases presented as severe illness, with a 10% of mortality. This data worried us in the beginning of the current outbreak, but fortunately, in our outbreak in our area, those rates were not as high. And also, important keratitis was a special feature that was described in one of the last outbreaks in Nigeria. What about the US outbreak in 2003? Well, in contrast with the outbreaks that were previously known, these cases were not as severe. The majority of them were mild, and also only there were just 3 complications regarding keratitis, encephalopathy, and lymphadenitis of the upper respiratory, with no deaths. So this outbreak in 2003 is more similar to the one that we are now living in our area. Well, here we see some clinical pictures of the monkeypox. Let's see how similar were these outbreaks in the children in the endemic countries, with several lesions, with a rash affected almost the entire body, that may resemble and that may be very similar to the rashes seen in the outbreaks of smallpox, as we can see here in this first picture. Okay. See also the great affection of the face with the monkeypox lesions that will eventually not just produce scarring, but also is a risk factor for develop keratitis and also other complications. Regarding human smallpox, just a few words. Human pox was the RAS was very related to the severity of the disease. But I find very interesting that the lesions of monkeypox are really very similar to those found in human smallpox. So that is a very similar disease, but human smallpox with higher rates of severity. And also, during these years, we have had a lot of research in pox virus. Actually, tecovirimat, which is, I will speak about it later, which is the main drug with indication against pox viruses, smallpox, and also monkeypox virus, has been developed because of the fear on bioterrorism attack with human smallpox, or the threat of a major pandemic or epidemic with human smallpox. So we now have a lot of research and a lot of knowledge about pox virus, because this threat, despite of this disease was eradicated like 45 years ago, a lot of efforts and a lot of research has been placed in these diseases because this fear to bioterrorism. Okay, so what we know now? Well, since May 2022, in many countries in Europe and also in the United States and other parts of the world, in America as well, we are facing a monkeypox virus outbreak, okay? But with different features that we previously know. We have the same virus because it's almost the same with a few changes in the genes that we have tested, that we have studied in the clades and in the analysis of the genome. And the most interesting is that the patient profile has changed. The patient profile that we have treated and that we have seen in this outbreak is different from what we knew about the reports and the cases described in endemic countries. As you can see here in this map, Spain has been one of the most, in Europe, the most affected country by monkeypox, with more or less 7,000 cases, between 6,000 and 7,000 cases. And we have seen cases since the alert, since the beginning. Here we have this interesting diagram where we can see that the worst part of the epidemic happened in around 15th of July, in the second week of July, where, for example, in our hospital, we could see almost 3-4 cases every day. So, and then the cases, the incidence is now almost getting zero, as we can see here in the last reports that are just a few cases in all the countries. So this is important to know, because for us it's a good news, because the infection has been just concentrated in a population and has not spread to other people. So this is important and a very good news. But we cannot, as I told you before, we cannot, relax, and we have to be prepared to maybe small outbreaks and also to major outbreaks in endemic countries of this disease. Okay, regarding the manifestations and the clinical picture and the clinical profile, it is important to know that the majority of the cases had dermatologic manifestation, has any type of skin lesions or rash. This is important because the dermatologist has played an important and a leading role in this outbreak and in this disease, not just for treating the patients for the diagnosis, but also for the research and for the publications and for the knowledge of the disease. It's a dermatological disease. Okay. Also systemic symptoms and lymphadenopathy that were symptoms that we previously known have been common in this outbreak. And other manifestations less common previously that we have seen now are, for example, proctitis or oropharyngeal manifestations and lesions that I will speak about it later. Okay, here this table is interesting because it compares the different outbreaks. Okay, this was published by our partners in London, and here the distribution. You see that in the last major outbreak in Nigeria in 2017, many or the most of the cases had involvement on the face and almost the entire body. But in our outbreaks, the main area involved in the skin lesions were genitals and perianal. Okay. And also the manifestation and the complications have changed from those respiratory symptoms that may lead to a complication, to a severe complication, encephalitis, to other complications related to the contact, to the sexual contact, that may be the rectal pain and sore throat, and also affection and complication in genitalia. So I want you to show this paper that I have the honor to participate, that was coordinated by the Spanish Society of Dermatology and Venerology, and also with the Spanish group of sexual transmitted disease. Several and many dermatologists in Spain from different hospitals coordinate to take all the cases of monkeypox, and then this research, and to know better and to explain better the manifestation and the features of the current outbreak. Apart of the demographics, the patient profiles and the symptoms that I will speak in a few slides, comparing with other papers published, I want to focus on one of our main findings and of our main description, that was the presence and description of this lesion that we refer as pseudopustule, because this may assemble the normal vesicle full of pus, but it's solid. This is important because it can help to the differential diagnosis, to know that this is not full of purulent content, but it's a solid lesion. Okay, and this was one of our main description in this paper. Okay, also in all these weeks, several papers have been published in other countries regarding the cases of monkeypox in, for example, UK, France, and also in other hospitals in Spain. So regarding I will do a brief summary of the main features of this outbreak, comparing these main papers and main publications of monkeypox. Well, regarding demographics, let's see that the majority of the cases were young men around 35 years old. Okay, most of them refer themselves as men who have sex with men, with multiple multiple sexual partners. We can see here that the median of the sexual partners in some series were almost 3-5 in the previous 2 or 3 weeks. And also, it was interesting that many of these patients related a previous sexual contact before the appearance of the lesion. So this talks about and favors the sexual contact as the main way of transmission of the current outbreak. About risk factors, it's important to note that many of these patients refer the practice of same-sex, and the previous trip in other countries was not so common, and in many of the cases, which is normal to see where patients that had not previously traveled to any other country. Another interesting feature is the co-infection with HIV in many of the patients that we have seen this in this outbreak. But despite of the large percent of cases with co-infection with HIV, this was not related to more severity or to different manifestations in this disease. This may be related to an adequate control of the virus in the majority of the cases, because the majority of the persons who get monkeypox virus and also they presented HIV were known HIV patients with treatment and with a good control on CD4 lymphocytes. So this may be the explanation for this unrelated severity. And regarding systemic symptoms, was important also. Maybe the most important feature was the skin manifestation, but almost the 50% of the patients related the systemic symptoms, which the majority of them was fever and also asthenia, myalgia, headache, etc. And another interesting thing and important feature was the incubation period. In our case, in our study, and also in the other studies that have been published, the median days were about 1 week, which differed from the previously published that were more like about 10 days, 2 weeks. Regarding the skin manifestation, another important feature, the majority of the skin manifestation, the skin lesions, were present in genitalia and perianal area, okay, which this is different from the other outbreaks. And very important, the dermatological absence was not common. So the majority of the cases that we have seen and have appeared in this outbreak presented with a skin lesion. Regarding the number of lesions, we have not seen patients with hundreds of lesions as previously described in, for example, the Nigeria outbreak. Most of them presented just about 5 or 20 lesions in the entire body, and the majority of them, these lesions were located in this genitalia and perianal area. Okay, here we have a diagram from the New England Journal of Medicine paper, which is very interesting because we can see here the evolution of the cutaneous lesion. Okay, as we can see, about 7 days after the contact, the wrist contact, the patient started with the systemic symptoms. Also here we see some other clinical pictures. Here we see the pseudopustule. This is a classical and typical lesion of monkeypox that we have seen in this current outbreak. But also, let's hear this face affection and this nose affection that may be different from the classical skin lesion. Well, as I've told you before, genital area has been the most frequent type of presentation during this outbreak, and this forces us to include this disease in the differential diagnosis among other causes, for example, of genital ulcers such as syphilis, herpes, or chlamydia. And also, this goes in lines of the mode of transmission, the leading mode of transmission of this outbreak that has been contact sexual. Here we see other skin types, skin examples of perianal, anal, and rectal lesions. see here the common and the typical lesion of monkeypox, sometimes involving almost the entire perianal area or the entire genital area, which was really painful for our patient. And sometimes the rectal symptoms or the perianal symptoms led to a decrease in functionality for this patient, a lot of pain. So this manifestation has been very difficult to treat in some cases. Here we see also some lesions and some cases of just one skin lesion, which is also an important and an interesting feature to know in order to do the differential diagnosis with syphilis, for example, or with herpes, because the first we think about when we hear about monkeypox virus is like general rash and a lot of lesions, but not. It also can happen just with a single lesion. Here we see other genital involvement with more than 1-5 skin lesions with the typical rash, with a typical monkeypox pseudopustule. This is also important to know and to for not just dermatologists or in infectious diseases doctors, but also for all the doctors, because the lesions in this outbreak have been very typical and very constant. I mean, it was not common to see a typical manifestation. Many of the patients that we saw with monkeypox virus disease presented with at least one or a few classical skin lesions. So it's better to at least suspect for a person who at least know the skin disease and know these skin lesions. Here in the perianal area, it's important to do the differential diagnosis for example, in this single skin lesion by monkeypox with other sexual transmitted diseases such as syphilis. And also oropharyngeal mucosa is an area very affected and very important in the current outbreak. Nasal and ocular involvement has been less frequent than expected and than previously published, fortunately, because it's a very severe complication that may lead to blindness, to permanent blindness. So overall, in those patients with severe or a spread skin lesions in the face or in the periocular area, we have to ask actively about ocular symptoms, about blindness or other symptoms or pain, ocular pain, because it is mandatory to. This is, I insist, this is very a potential severe complication and is an indication for tecovirimat, for antiviral drug treatment. Regarding the oropharyngeal mucosa, it has been relatively common complication in this current outbreak, and the important thing is that it's related to a more insidious and complicated picture because it may compromise the airway. So all those patients with skin lesions or monkeypox lesions in the tongue or in the amygdala or in the lips, we have also to ask actively about respiratory symptoms, and also we have to explore the neck and the oropharyngeal area to at least to test that the patient can breathe properly. And oropharyngeal mucosa and the affection, for example, of the amygdala has been hypothesized with asymptomatic carriers, but we don't know. This is just an hypothesis. Okay, here we see some examples of these lesions in the perioral and also oral mucosa area. And this is not just important because the direct affection or the skin manifestation in the mucosa, but also because the lymphadenopathy, because patient with several skin lesions, for example, in the lip, has more risk to develop a large lymphadenopathy in the neck and the cervical area that may as well compromise the airway or produce an airway obstruction. Here we see other example. For example, this amygdala involvement, which is very serious and a very important complication or a manifestation that may be related to serious problems. Well, proctitis has been related to anal sex and perianal lesions. So it's important also to ask actively about the lesions or the symptoms in this region to all the patients, because this is a typical and a novel manifestation, and is related also not just with complications, because some patients is not common, but some patients could have an increased risk, for example, of colitis or even perforation. But it's a very painful symptom. It's a very painful symptom, and we have to put analgesia and we have to use direct drugs to treat the pain in the patients affected with proctitis. And also, this has been related to an hypothesis of asymptomatic carriers in those with proctitis or with lesions and symptoms related in this area, in this mucosal area. Well, lymphadenopathy, very constant, very common, mainly inguinal lymphadenopathy because of the inguinal, perianal, and genital involvement, but also cervical. Remember that the cervical and the neck affection of the lymph nodes is related to severe or complications. So we have to examine our patient and to find this manifestation to avoid complications. And also, lymphadenopathy is an interesting feature because it helps us in the differential diagnosis. Because in contrast with other skin infections, monkeypox virus disease produces a large lymph nodes enlargement and painful. Concomitant sexual transmitted infections and disease were also common in the patient, not just in our case series, but also in other published reports. It is related, of course, to the transmission route, and this is mandatory when we see when we confirm a case of monkeypox virus disease. It's important to actively search for other sexual transmitted infections in all these patients. Well, what about other population? What about monkeypox in children? In my experience in our hospital, we have not had monkeypox in children. We have not seen any case, but there have been a few cases published in the literature, and also a case series of infant cases in Spain. Well, just a few ideas. Okay, for example, this case published in JAD was thought to be related to immunoglobulin A deficiency, because these cases was not related to any contact with other monkeypox patient. So the authors hypothesized that the IgA, as the IgA neutralized the virus at the mucosal level, this suggests that the respiratory transmission may have played a role in transmission of the case, because the hair transmission, at least in our area, in our outbreak, has not been a main route of transmission of the disease. It has been the contact, skin-to-skin transmission, more frequent. On the other hand, here we have a case series of monkeypox virus infection in children, and just a few ideas. The rash and lymphadenopathy was almost constant in all the patients, similar as in adults, but as expected, many of the cases were related to household contact, and one of the cases was unknown, the contact. Other cases this is interesting because these 9 cases were related to contact with contaminated material in the context of a tattoo salon, and there were no complications, and all the children survived. This is important to know because the children in the previously reported outbreaks were considered a high-risk population next to the pregnant woman and also immunocompromised patients. So children, a case in the children is important to vigilate and to find actively complications, because it at least in the cases that occur in Nigeria or other endemic countries, the children develop worse outcomes. Okay, so, and also because the viral exanthems and viral rashes are more common in children, so this allows us to make differential diagnosis, not just with herpes simple, with pangina, with parvovirus, but also with monkeypox virus. Here we see, for example, Coxsackie virus infection, that these lesions, I like this picture, I like this photo, because let's see that they may resemble monkeypox viral infection. So it is important to know. It's important to know this disease. Okay, and do not forget that also in children the molluscum contagiosum is very frequent, and despite of the lesion of molluscum contagiosum, may quite resemble the monkeypox virus lesions, but are not as inflammatory, are more solid. But it's important to know to make the differential diagnosis, because sometimes, for example, in this other picture in the bottom of the slide, we see a molluscum contagiosum which is inflamed, which is irritated, that may resemble a lesion by monkeypox virus. Okay, let's see here another differential diagnosis. The typical herpes simple or herpes zoster lesion with this vesicle in a spot, in a red spot, compared to the typical monkeypox virus lesion with this pseudopustule, with this necrotic center that is very typical and very constant in the monkeypox virus disease. And also do not forget about other sexual transmitted diseases when doing differential diagnosis on when exploring patients with monkeypox virus. Overall, if the transmission is suspected to be by a sexual contact, because we have seen, and it has been published, that the concomitant sexual transmitted disease are common in patients affected by monkeypox. also stings, and also, of course, other dermatological conditions, not infectious diseases, such as inflammatory diseases, such as vasculitis, fever gangrenoso, and so on. And also, ORF virus, that it's another is a parapox virus, but it's also a pox virus, and very less frequent, but with lesions that may resemble as well monkeypox virus. Well, and to finish, what about the complication? Myocarditis is defined. It has been described, and in our hospital we have had one case of myocarditis related to monkeypox virus infection with a very good outcome. Encephalitis is not common, at least in my experience. I have seen no encephalitis, but for example, in Spain, the cause of death of the only 2 deaths in Spain were related to encephalitis. And very important, bacterial superinfection, because this is a very common complication. It may be related to the local relative immunosuppression that provokes that the virus provokes, and it's important to treat actively, because this inflammation, this infection, may increase the risk of scarring. About the treatment, we have performed symptomatic treatment, because tecovirimat was not we didn't have tecovirimat, was not available, just a few doses, restricted doses for complications, or for patients with a severe illness, that were just a few. But for example, the patient with the myocarditis was treated with tecovirimat. About the symptomatic treatment, analgesia, very important, especially in proctitis, patients with proctitis or with perianal involvement, mupirocin, septomide, or prednisone to decrease the inflammation, and systemic antibiotic if we suspect superinfection. And also tecovirimat in those cases more severe, or if we have the drug, if it is available, pues, well, it's a very good option, because it has the indication. But also we have cidofovir and brimcidofovir that are not, they have not the special indication to pox virus, but are useful. And also Imvanex, which is the vaccine that has been used in the current outbreak, is a 3rd generation vaccine with fewer side effects. I want to finish, but I want to thank my residents in my service, that they have helped me a lot with in this current outbreak. They have doing a great work, a great job, seeing the patients, treating the patients, and also in the follow-up. And in conclusion, I want to stress the importance of emerging infectious diseases. It's clear, it's a fact that we are facing new outbreaks with new viruses, with new pathogens, and we will face new ones. So we have to coordinate. It's really important, and it's a need, the coordinated work between specialties and also between dermatologists and colleges to face and to answer these outbreaks and these new epidemics in the best way. Regarding the current monkeypox outbreak, very important to know the skin lesions, because they are almost constant in all the patients, and it allows to make a correct differential diagnosis and to recognize the disease, and also to take into account the new clinical forms that were not described previously, such as, for example, the proctitis, the genital involvement or the oropharyngeal involvement. And we will have to answer questions now, like the possibility of endemicity in our area, that the importance to watch and to vigilate the disease in endemic countries, to know if asymptomatic carriers are a fact or if they are important in transmission of the disease. Also to investigate and to describe the long-term injuries and the best way to treat them, for example, the scars or the scarring sequela, and also if mass vaccination or vaccines in other populations may be useful or may be necessary for prevent future outbreaks in not just, I insist, in our context, in our area, but also in the endemic countries where this is still a problem. So thank you very much for your attention. Thank you very much for the GloDerm committee for giving me this opportunity to explain my experience and my point of view of this disease. And you are very welcome to ask any question you have. Thank you very much.
Thank you very much, Pablo. It was really interesting and really elucidating. I think that everyone who will be watching this lecture will enjoy. And I have some questions. Some of them you answered along your presentation, especially concerning monkeypox in children, which I was really curious about. But the first one I have is from your experience. You're based in Spain, right? Which protocols do you use for the collection of these samples? Because here in Brazil, the protocol, we collect 5 samples in total. So they tell us to collect the secretion of the skin lesion, the crust, if it has a crust, and a urine sample, blood sample, and also I think a swab from the oral cavity to send them for molecular biology. And how do you, from your experience, what do you do in your country?
Well, that's a very interesting question. In our protocol, we collected monkeypox virus samples from the skin lesion, from the oral throat, from the from rectal sample, and also we collected samples for gonococcal and chlamydia. Also for PCR, and a blood sample to test and or to know other, for example, HIV or syphilis or other sexual transmitted disease. Those were the samples that were collected in every patient that went to our emergency department or to our consultation with a monkeypox suspicion.
Yeah, it's really interesting because you mentioned as like a lot of your patients had STD related to the monkeypox, you already send them to see if there are other disease. Yeah. So one thing that after reading your paper that I thought is really interesting is about the I think it was like 10% of the people of your patients that were vaccinated for smallpox.
Yeah,
and they got the disease, right? So I was like, oh my God.
Yeah, that is difficult to explain because for 2 reasons. First, because many of the patients, they don't know if they are vaccinated with variola, with measles, with rubella, with mumps. So for us, we had to ask about the vaccine scar. And we expected that all those patients who were born before 1980, they were vaccinated. Despite of they didn't remember, we suppose that they were vaccinated. It is true that it is considered that the vaccine protects about 85% for the disease. It's an estimation. So we don't know if maybe the vaccination, the previous vaccination against smallpox is protecting the population, and we just saw those 15% of the cases that are supposed to not be covered by the vaccine. We don't know, because we thought about doing like a serological test, but finally with the microbiologists discussing this test with the microbiologists, they didn't found it, suitable, because so just an hypothesis.
Yeah. And do you recommend, like, for the contacts or health workers to get vaccinated after the contact of the patient, or you don't?
Well, it depends. It depends on each one. The transmission among health workers has occurred, but it's not very common. It's just a few cases. In my experience with contact measures, like gloves, like mask, for me and for the rest of my partners has been enough for not getting the disease. Okay, just these measures. But well, the indication also is not just for the people in risk, but also for the health workers. So if someone who attends this patient want to vaccinate, it's indicated.
Yeah. And do you know if they are developing any other like vaccines? Because with the changes in the genome that you presented in the beginning of the lecture, or it's the vaccine is kind of the same as the smallpox one?
Well, as far as I know, I think that they are not developing a new vaccine. Why? Because it is considered that the smallpox vaccine, the vaccine virus, presents a full coverage against monkeypox virus disease. And regarding the genes changes in the monkeypox, in the virus, well, there is controversy, because it is known and it is clear that there have been changes in the full genome, but it's not well known if these changes are related to difference in the behavior of the virus, right. Because we have to remember that this is a DNA virus, and DNA virus are quite different from RNA virus. RNA virus tends to mutate more, because it's evolution to mutate to survive. But DNA virus are more constant. Actually, all these proteins that they encode allow them to evade the immune system. So they are very constant in this aspect. So to sum up, I think that the smallpox vaccination will cover monkeypox, and I don't find it necessary to adapt the vaccines to new, to new types of virus.
Sure, yeah. And two more questions. The first one, so the main transmission of monkeypox is based on, of course, exchange of fluids between patients and contact with the lesions. Like the respiratory tract transmits a really low dose of the virus. Is that correct? What's the incidence of transmission?
So the question is if the low dose of the virus with the transmission
within the oral tract and particles from respiratory tract.
Okay.
Is it high? No.
Well, it is described as a way of transmission, the oral or the respiratory way, apart from, of course, skin to skin and close contact transmission. But in our experience and what we have seen in this current outbreak, the oral transmission and the airway transmission it's not as effective. It's not as effective
great.
because we would have seen more cases not related to close contact, and the majority of the cases were related to close contacts or people living in the same house. So actually, in the I don't remember now, but I think the Lancet paper, they performed the PCR samples in the airway and they measured the viral load, and they didn't find higher viral load in the airway. So they made the hypothesis that this way in transmission is not as effective as the close contact or skin-to-skin transmission.
Oh yeah, that's good. COVID was enough, right?
Yeah, absolutely. But that was what. But it's an interesting question, because when the alert began, that was one of my main concerns, that this could be spread in the airway. Actually, I spoke with doctors, with partners that works in an special unit of isolation in Spain, to know if we had to isolate the patient, because imagine that this virus or this disease, this outbreak, would have been more effective than the airway transmission. It could be like another pandemic, like another COVID.
Yeah, sure. And the last one, I was curious about your experiences concerning the scars of the patients. Did you notice a lot of scar formation after they heal from the monkeypox lesions? Or do you use any, I don't know, Vaseline creams, silicone creams to heal, or let it heal naturally? What's your experience concerning that?
Well, so far, I have seen several patients with all the lesions completely cured, and in our hospital we are offering them laser treatment for the scars. In some selected cases, for example, scars in the face or scars in the arms, and also the typical recommendation for scars like photoprotection, especially because the outbreak occurred in the middle of the summer, so many patients had, sun exposure. But scars are not very common. Not every patient develop scars, but some of them they have scars. They have acne scars. That appearance.
Great, thank you. I think that's enough for questions. Thank you very much for the lecture. I think now Dorian will close up the section.
Thank you, Dr. Pablo, very much for your very informative and very interesting study and lecture that you just gave us on monkeypox. But before, I know I'm supposed to close this, but I have a small question,
you're welcome.
Following the conversation that we're having about changing I was thinking maybe with this climate change, because looking at COVID was primary from the animals, and now monkeypox from the animals. Do you think that it might be related to the climate change, or it's just human behavior that are changing now and then causing all these outbreaks and pandemics? What do you think about that?
Well, I think that all the factors are related to these outbreaks, to epidemics. Why? Because now we have a lot of movement of people that live near jungle or places with a lot of wild animals, and they establish a close contact between population and wild animals, and also international trips. Also, the presence of a new species, or for example vectors like mosquitoes, in areas where we didn't know them before. So, and in the special case of monkeypox, it has been also related to the decrease in the smallpox coverage vaccination. You know, if there are more people that may get an infection, it's more common to appear. But undoubtedly, we have to get prepared. We have to know. We have to watch all these diseases that may be located in some parts of the world, because they can become global in any time. You know, is the concept of One Health.
Yeah.
Okay. Oh, thank you very much. I think we will keep collecting questions now from for the audience when we upload the video, and maybe we will plan how you can answer them, either replying on the chat or maybe doing another recording of you answering the questions. So thank you very much. I'm closing this session. Thank you, Dr. Riza, for the very good questions.
Thank you.
So yeah, I think we are done. Bye.
Yeah, bye. Thank you, Pablo.
Thank you very much.
Again.
Thank you very much for giving me this opportunity. Bye-bye.
Bye.
Bye-bye.
See you soon.